Hello everyone, welcome to Easy Medicine. This is the second section of cardiomyopathies where we are going to discuss restrictive cardiomyopathy and then dilated cardiomyopathy. So let's look at the restrictive cardiomyopathy. Restrictive cardiomyopathy is one such cardiomyopathy where the ventricular myocardium is getting deposited with some other extra cardiac matter and the ventricular volume is significantly reduced. So the ventricle becomes very stiff and non-compliant. That is what is restrictive cardiomyopathy. So the etiology includes the most common ones are the infiltrative disorders or the storage disorders. Among them, the most common one is amyloidosis, which is amyloid light chain type or ATTR, amyloid transthyretin receptor, wild or mutant type. Then we have sarcoidosis, hemochromatosis, Fabry's disease, glycogen storage disorder 2, that is Pompe's disease. And then when you look at the causes of endomyocardial fibrosis, where the myocardium is now replaced with fibrosis, the examples are the carcinoid syndrome, radiation exposure, use of ergotamine and ergot-related drugs, and scleroderma, which is an autoimmune disorder or a rheumatological disorder. Now let's look at the pathophysiology. Before going to that, let's just recollect the different shapes and morphological characteristics of each and every cardiomyopathy. Now we are going to discuss about the restrictive cardiomyopathy in this class. So observe the biventricular hypertrophy. So the problem is on both the sides. There is right ventricular hypertrophy as well as the left ventricular hypertrophy because of infiltration of some other extra cardiac matter. So what heart sound will develop when there is a non-compliant and stiff ventricle? There is development of S4. And because the ventricle is not accommodating blood and there will be regurgitation of blood from ventricle into the atrium, that is in the formation of tricuspid regurgitation, and tricuspid regurgitation will generate a functional pansystolic murmur. And when the blood keeps on pulling in the right atrium, the patient will develop dilatation and enlargement of the right atrium, and eventually the patient may develop atrial fibrillation as well. So that is visible. The increase in right atrial pressure is visible in the form of elevated JVP, and eventually the patient may develop bilateral pedal edema, congestive hepatomegaly. So all these are the features of the backward failure of the right heart or the right heart failure simply. So left, when you look at the left side, so there is the left ventricular hypertrophy as well, and the patient will develop LVS4. So the extra heart sound that is generated here is left ventricular S4, and similar to that of the right side, there is mitral regurgitation here, and the patient will have pansystolic murmur because of it. And similar to the right side, we have dilatation of the left atrium as well, and the patient will have atrial fibrillation because of that. And hence there is dilated left atrium. The congestion of the blood in the left atrium will exert back pressure onto the lungs, and lungs will also get congested, and the patient will have shortness of breath because of congestion of the lung. And because the ventricular cavity is not filling with sufficient amount of blood, the blood being ejected from the left ventricle into the aorta is also reduced. So there is reduced cardiac output and reduced systolic blood pressure, and the patient will have fatigue. So what are the clinical features? If you have understood the pathophysiology, deduction of the clinical features is very easy. So the patient will have fatigue, dyspnea, and edema. Of course, a combination of right heart failure and left heart failure features. Of course, the restrictive cardiomyopathy mainly causes diastolic dysfunction. The pulse can be bradycardia and heart blocks because the infiltrative matter, whatever the extracardiac matter that is getting deposited in the ventricular myocardium, will also deposit in place of the conduction system, and there are conduction blocks. That is why there is bradycardia and heart blocks. When you look at JVP, the JVP is elevated. Usually the patient will have S4, and there can also be S3 when the patient is in failure. And murmurs like pansystolic murmur can be seen because of tricuspid regurgitation or mitral regurgitation. And usually in this disease, since this is predominant diastolic failure, ejection fraction may be more or less preserved. So LV ejection fraction is preserved till late in the disease. Now let's look at the evaluation. Starting with the basic investigation, which is an ECG. ECG will show low voltage complexes and diffuse ST wave changes. If you recollect what we have seen in hypertrophic obstructive cardiomyopathy, the hypertrophic obstructive cardiomyopathy is because of the asymmetrical hypertrophy of the septum and the left ventricle. So there is features of LVH and septal Q waves, and of course the ST wave changes because of left ventricular strain. All these features will be seen at HOCM, but here, why do you think there is low voltage complexes? Because the matter that is depositing in the left ventricle and the right ventricle is not the myocardium, it is some other extra cardiac matter which is not very efficient in electrical conduction. That is why there is low voltage complexes in restrictive cardiomyopathy. And when you look at the echocardiography, you will see right ventricular hypertrophy, left ventricular hypertrophy, left atrial enlargement, and right atrial enlargement, as we have seen in the pathophysiology or the hemodynamics. So the MRI is useful for the assessment of myocardial fibrosis, determination of etiology, and exclusion of constrictive pericarditis. So on endomyocardial biopsy, you can find what extracardiac matter has deposited, and that is going to give you the diagnosis of the patient. That is the etiological diagnosis of the patient. Now, when you look at the treatment, the patient is obviously in diastolic failure. First, you treat the patient of heart failure. And you can use nitrates and diuretics, but use them cautiously only when they are required. And try to avoid digoxin because that can precipitate arrhythmias in these patients. And the only cure for this patient is transplantation. But recently, a drug called as tafamidis has been approved by FDA for ATTR, that is transthyretin receptor cardiomyopathy, causing because of amyloidosis. Now, for the second time, let's look at all the morphologies of the heart because we have moved to the next topic, that is dilated cardiomyopathy. Appreciate all the chamber enlargement. You can see the right atrium is enlarged, left atrium is enlarged, right ventricle is enlarged, as well as the left ventricle is enlarged. And you can appreciate when you compare it with the normal myocardium or with the HCM and RCM, you can see the ventricular wall is significantly thinned out and there is systolic dysfunction here. We have discussed this in the heart failure lecture as well. There is diastolic failure in restrictive cardiomyopathy and systolic failure in dilated cardiomyopathy. So let's start with this dilated cardiomyopathy, starting with the etiology. Firstly, let's start with the infectious causes and non-infectious causes of myocarditis. The infective causes are usually the viruses like Coxsackie virus, adenovirus, HIV, and HCV. Bacterial causes like Lyme's disease, Q fever, and diphtheria can also cause myocarditis. And we have some parasites as well. They are Chagas disease, toxoplasmosis. And lastly, we have the fungal myocarditis as well. So any of these different kinds of organisms will result in infective myocarditis in the patient. And certain non-infective causes where there is significant inflammation in the ventricular myocardium that is resulting in left ventricular dysfunction, that is left ventricular systolic dysfunction. They are the dermato or polymyositis, collagen vascular disorders like SLE, then we have sarcoidosis and eosinophilic myocarditis. I hope you appreciate the sarcoidosis can result in both restrictive cardiomyopathy as well as dilated cardiomyopathy. Now we have some more causes. We have familial causes. The most common mutation is the titin gene, and we have some other muscular dystrophies like Duchenne muscular dystrophy, Becker's muscular dystrophy, and Kearns-Sayre. And we have certain toxic causes. The most common one is alcohol, and followed by usage of cocaine, anabolic steroids, amphetamines, and certain drugs, anti-cancer drugs like doxorubicin, daunorubicin, and trastuzumab. All these drugs will result in this dilated cardiomyopathy. Now, when you look at the endocrine causes, hypo or hyperthyroidism, both of them can result in this dilated cardiomyopathy. Pheochromocytoma, again because of excessive catecholamines, can result in this cardiomyopathy. Diabetes, hemochromatosis, all these endocrine disorders can also result in dilated cardiomyopathy. We have certain metabolic causes as well, where the deficiency of certain important ions like calcium, magnesium, phosphate, selenium, and carnitine. All these deficiencies can also result in dilated cardiomyopathy. Now, uncontrolled tachycardia for a long period of time, if the patient is not intervened with some drugs, the prolonged tachycardia can also result in dilated cardiomyopathy. There is a certain phenomenon called as the peripartum cardiomyopathy, which can occur after delivery to 6 months after delivery. During this phase, the patient can develop transient myocardial dysfunction, that is transient systolic dysfunction, and it is called as the peripartum cardiomyopathy. Now, overlap with non-dilated cardiomyopathy. There are two disorders which will result in both a dilated cardiomyopathy in combination with a non-dilated cardiomyopathy, that is a hemochromatosis and amyloidosis. So, both of them can result in either a restrictive cardiomyopathy or a dilated cardiomyopathy. Now, let's look at the pathophysiology. So here you can appreciate all the four chambers of the heart are significantly enlarged. So the left ventricle, right ventricle, left atrium, right atrium, all the four ventricles are dilated or enlarged. And here starts the problem. So dilatation of the right ventricle. So when the patient is in failure, the patient will develop S3. So this is RV S3. And because of the enlargement of all the ventricles, the annuli of the mitral and tricuspid valves will also increase. So the tricuspid annulus as well as the mitral valve annulus will also increase in diameter, and that will result in tricuspid regurgitation on the right side and mitral regurgitation on the left side. So you can appreciate the right atrium is also dilated. And further, the blood pull-up is visible in the form of elevated JVP and pedal edema, similar to that of the diastolic failure. So whenever the patient develops systolic failure first, See, systolic failure means the blood is not going to move forward from the ventricles into the aorta or into the pulmonary arteries. So where will the blood go? The blood will eventually have to pull up, and the patient will also develop diastolic dysfunction eventually. So systolic dysfunction will also have the features of diastolic dysfunction eventually. So the patient will also have elevated JVP and edema. So when you look at the left side, there is dilation of the left ventricular as well, and when the patient is in failure, there will be development of S3. This is LVS3. And since the mitral valvulus is also increased in size, the patient will have the mitral regurgitation and the patient will have this pansystolic murmur because of this mitral regurgitation. As you can see, the left atrium is also dilated and that will result in the generation of atrial fibrillation in the patient. Of course, because of the pulling of blood in the left atrium and further pulling of blood in the pulmonary veins and the lung, and the patient will develop shortness of breath because of this pulmonary congestion. Because of the forward failure, there can be reduced cardiac output, reduced systolic blood pressure, and the patient will have fatigue as well. Now, when you look at the clinical features, all the features of heart failure are present in the case of dilated cardiomyopathy. We have looked at, if you remember a class from heart failure, a patient of dilated cardiomyopathy will have the forward failure of the right and left hearts, backward failure of the right and left hearts. So all the features of heart failure will be seen in a case of dilated cardiomyopathy. On examination, you will find, of course, when the patient is in failure, you will see S3, a third heart sound, and a murmur of pansystolic murmur or tricuspid regurgitation murmur may be heard, and the apex will be shifted down and out. This is the difference. When you look at the restrictive cardiomyopathy, there is no shifting of cardiac apex because there is no eccentric hypertrophy. There is only deposition of extracardiac matter in the inside of the ventricular cavity, and hence there is probably some concentric kind of hypertrophy. It is actually not hypertrophy though. There is deposition of the extracardiac matter in the ventricular myocardial cavity and the ventricular cavity is reduced. But in dilated cardiomyopathy, the ventricular wall is significantly thinned out and there is eccentric enlargement of the left ventricle. So the apex will be obviously shifted downwards and outwards. Now let's look at the myocarditis. The myocarditis presentation is little different because it is frequently followed by a simple viral infection. That is why, and the patient will also have sudden severe deterioration in the left ventricular systolic function, and the patient may land up in heart failure even though the patient is young. That is why myocarditis have to be learned properly. So the myocarditis can be a fulminant presentation, or the patient can be subclinical, or certain times the patient can also have a chronic heart failure. Now, when you look at the myocarditis, we need to understand myocarditis separately because this can result in sudden severe deterioration of the left ventricular systolic function, and the patient may end up in heart failure, irrespective of the patient's age. Even this is actually the one of the commonest causes of heart failure in quite young patients. So this can be fulminant or subclinical or chronic heart failure. Usually, the onset is few days to few weeks after an acute febrile illness, and the patient will present to you with dyspnea or the other features of heart failure. Frequently, the patient can also have chest pain and tachyarrhythmias. Because of failure, you will also appreciate S3 gallop in the patient, and pericardial friction rub may be seen when the patient is having associated pericarditis as well. So, the usual labs will show you the presence of heart failure. Of course, the lab investigation which indicates that the patient's left ventricle is in quite strain is NT-proBNP. And the troponins is also elevated because of inflammation of the myocardial tissue. And when you look at the echocardiography, you will find cardiomegaly and left ventricular systolic dysfunction. Now let's look at the evaluation. Again, start with the basic investigation, which is an ECG. ECG shows you the variable STT changes, poor RY progression, conduction defects, and arrhythmias. So the ECG features may be quite varied in the patient of DCMP. And chest X-ray will reveal cardiomegaly because all the chambers of the heart are significantly increased in size, and you can see that the heart is globular in shape. And by doing a 2D echo, you will find systolic dysfunction, all the four chambers which are significantly enlarged, and there is global hypokinesia. The movement of the ventricular walls are significantly reduced, and of course, the ejection fraction is reduced, and the valvular abnormalities which have developed now because of the enlarged mitral and tricuspid annuli, they are nothing but mitral regurgitation and tricuspid regurgitation. And because of this enlargement of the left ventricle and as well as the right ventricle, and because of reduced pumping action, so there is possibility of stasis in the ventricular cavities, and eventually the patient will develop this mural thrombi. And the cardiac MRI will assess the presence of myocardial fibrosis. It will assess the myocardial viability and if there is any presence of myocardial scar. The endomyocardial biopsy is not routinely required. It is actually required for the diagnosis of restrictive cardiomyopathy because there is deposition of extracardiac matter which is easily identified with an endomyocardial biopsy, but that is not the case here. We have the diagnosis, that is dilated cardiomyopathy, and it should be used to rule out a treatable cause. Otherwise, there is no role for endomyocardial biopsy in a diagnosis of dilated cardiomyopathy. And coronary angiography should be done in selected patients because previous myocardial infarction or coronary artery disease will result in this DCMP eventually in a later part of life. That is why if you are suspecting a case of a coronary artery disease background in a patient of DCMP, only then you will do coronary angiography. So you also have to do some investigations because we have looked at a huge load of etiological factors for the development of DCMP. Now, when you look at the treatment, firstly, treat the heart failure and also treat the cause. So we have elaborately discussed about the management of heart failure in the heart failure section. Go through that, you'll be able to handle it. And of course, after you treat the heart failure, if at all possible, if there is a treatable cause, treat the cause also. Now, this is the last time I'm projecting this image in this lecture. This is only to go ahead lastly with the differentiation between the hypertrophic cardiomyopathy, restrictive cardiomyopathy, and dilated cardiomyopathy. So let's differentiate between them. Now, the ejection fraction in hypertrophic cardiomyopathy is preserved, and the ejection fraction is more than 60%. You can see the left ventricle is asymmetrically thickened with the septal hypertrophy as well as the left ventricular hypertrophy, so the LV thickness is increased. And because of the hypertrophied septum as well as the left ventricular concentric hypertrophy, the left ventricular volume is reduced or it may sometimes be normal. Because of the mitral regurgitation and pooling of blood in the left atrium, there is left atrial enlargement, and valvular abnormality here is mitral regurgitation. The first symptom is shortness of breath or chest pain. Usually, the patient will have the microvascular angina because of increased demand and reduced supply, and the patient will have chest pain. So the congestive features are predominantly present on the left side because the septal hypertrophy and the ventricular hypertrophy, both of them are more prominently seen on the left side, and hence the congestive symptoms are also more prominent on the left side. And what kind of arrhythmias do you see? Because of the ventricular myocardial thickness is increased and the blood flow to the ventricular myocardium is also diminished because of the reduced cardiac output in case of exercise. So there is demand supply mismatch and the patient will have microvascular ischemia and microvascular infarcts. So the microinfarcts result in the development of reentrant circuits and the patient can develop ventricular tachycardia or ventricular fibrillation. This we have discussed in the chapter of VT or VF. Now, in case of restrictive cardiomyopathy as well, you can see the restrictive cardiomyopathy is predominantly a diastolic failure and the ejection fraction is preserved and LV thickness is increased because of deposition of certain extracardiac matter but not because of the ventricular myocardium itself. And the LV size is again reduced or maybe normal because the inner side of the ventricular myocardium is filled with this extracardiac matter mainly. And the atrial size is increased on both the sides because there is biventricular hypertrophy in the patient. And of course, the valvular abnormalities are both mitral regurgitation and tricuspid regurgitation. The first symptom is shortness of breath, or the patient may present with right heart failure. The congestive symptoms are more prominent on the right side here than the left side. And arrhythmias that you can see are because of this extracardiac matter replacing the ventricular myocardium as well as the conduction system, the heart blocks are the most common arrhythmias here rather than atrial fibrillation. Of course, because of the eventual enlargement of right atrium and the left atrium, the patient can also develop atrial fibrillation, but AV blocks are commoner. Now, when you look at the dilated cardiomyopathy will result in heart failure with reduced ejection fraction. So the ejection fraction is less than 30%, and the LV thickness is significantly reduced. You can see if you have observed in the image, the ventricular wall thickness is significantly reduced and the ventricular size is increased. So there is eccentric or enlargement of the left ventricle, but with the thinning of left ventricular wall. So the LV size is obviously increased. So there is all the chambers which are enlarged, and the atrial size is also increased. Left is more than right. And the valvular abnormalities are obviously mitral regurgitation and tricuspid regurgitation because of the enlargement of mitral and tricuspid annuli. And the first symptom is again shortness of breath. The congestive symptoms are more prominent on the left side here because there is systolic failure. Firstly, when there is left-sided forward failure, and the patient will eventually develop left-sided backward failure, and then the backward failure of the right heart. So the arrhythmias that you commonly see are ventricular tachycardia, atrial fibrillation, AV blocks in Chagas disease. So all the kinds of arrhythmias that we have seen in previous tachyarrhythmias can also be seen here. So this is a glimpse of all the cardiomyopathies in a single slide. Hope you understood this. If you find value in this video, please share this video to your friends and subscribe to this channel. Thank you.